Hi, everyone. Thanks so much for being with us today. Apologies that we're starting just a little bit late, but welcome to our webinar. My name is Kim van der Weijden, and I'm a project manager at Transaid. I'm joined today by my colleagues from the project Community Capacity for Health, which is locally known as Mahefa Miaraka in Madagascar. So I'm joined by Dr. Yvette Ribara, who's Chief of Party for this project, and by Maheri Ramanantwan, who was the Regional Behavior Change and Communication Mobilization Officer. And we were also going to be joined by Dr. Isaka Rabison, but unfortunately he's been in the field doing very important work for us. So we'll be covering for his section today. So just a few housekeeping items as we start this webinar. So the presentation is being recorded. That way the presentation can be watched by those who are unable to join, and all those who joined and signed up will receive a copy of that in your inbox. Please also feel free to introduce yourself in the chat box with your name and your affiliation. And if you do have any questions as we're going through the presentations, there should be an orange question mark button. So please submit any questions that you have via this button. And then just also, if you can include who the question is being addressed to, then we will address all of these questions in the Q&A session at the end. So we're going to go ahead and start, and I'm going to pass it over to Dr. Yvette Ribara, and she's going to give us a more detailed introduction into Madagascar and the project.
Thank you, Kim, and good morning, good afternoon, everyone. What is the Madagascar context that we can share today? So according to the most recent general census on population, Madagascar has nearly 26 million inhabitants throughout the country, 4/5 of whom live in rural areas. In these areas, access to health care remains a challenge, and delays in reaching care become the norm, especially for pregnant women, due to long distance to health facility, poor infrastructure, or lack of transportation. And as a result, most of births take place at home without assistance from skilled birth attendants. Next, please. Next slide, please. In response and as a contribution to support the government of Madagascar through the Ministry of Public Health in achieving its universal health coverage goals, the U.S. Agency for International Development awarded the 5-year Community Capacity for Health program to JSI Research Training Institute, Inc. from June 2016 to September 2021. The program reflected USAID's commitment to providing high-quality community health services that integrated with the formal health system, addressing key drivers of maternal, newborn, and child mortality, and responding to client needs while promoting the importance of community health in contributing to the government of Madagascar efforts to reduce maternal, newborn, and child mortality. The project implementation was a joint collaboration between GSI and 3 partners: Family Health International 360, Transaid, and Association Socio-Sanitaire Organisation Secours. Integrated health interventions aimed to strengthen the public sector capacities to plan, deliver, and manage community health services, and to strengthen community engagement in health. In regard to our today's webinar, we'll focus on sharing our experience on improving the access to healthcare for underserved communities in rural areas by addressing emergency transport. Next slide, please. Next slide, please. So as shown in brown color in the slide, so the project worked in 7 regions out of 22 in all villages of 34 districts to promote and deliver integrated basic health services through 10,000 community health volunteers who provide basic maternal health, child health, and family planning services to their local community. The project had the potential to serve approximately 6.6 million people, representing the 28% of the country's total population. Next, please. So in these supported regions, 44% of communities are inaccessible by vehicles for at least 4 months of the year, and 20% are inaccessible for almost half of the year. Consequently, with Transaid expertise, the project developed enterprise boxes for bicycle sales and repair to facilitate community health volunteers' mobility and as a financial incentive for community actors. In addition, the project developed community emergency transport systems by 1, helping communities to make a formal structure plan when operating their emergency health evacuation plan from their location to the basic health center, the first contact to the national health system. And second, introducing, monitoring, improving intermediate means of transport when appropriate. And third, mobilizing and partnering with public transport cooperatives to be part of the community emergency health evacuation plan and to implement it. To understand more how we came to the choice and the effective integration of a public transport into the community emergency evacuation plan, I pass the floor to Kim. Over to you, Kim.
Thanks so much, Dr. Yvette. So I'd like to take everyone back a little bit because Transaid and JSI have been working on activities related to access to healthcare since the initial Mahefa program, which was initiated in 2011. And this project had many great achievements, but we're going to focus today on the activities that are specifically related to a rather novel activity that we carried out relating, as Dr. Yvette mentioned, to the emergency transport using publicly available transport. So during Mahefa, the original program, one main activity was the introduction of intermediary modes of transport, also known as IMTs. And this was to help communities better access healthcare. And IMTs are locally managed modes of transport, and they're adapted for the terrain and hard to reach communities. So here you can imagine the use of ox carts, kayaks, bicycle ambulances. However, when we were working during Mahefa and during Mahefa Miaraka, it was really evident that community members were also frequently relying on public transport to access healthcare. And this included transport such as the taxi brousse, which other people might know as a bush taxi, bajaj and cyclopus, which are motorized and unmotorized three-wheelers and motorcycles. This was both for short distance trips to local health posts as well as longer trips to health centers and hospitals. And so this already shows, and it showed us that these modes of transport were already accepted means, not only for day-to-day transport, but also for the emergency context. And the drivers and vehicles were also quite well adapted for these situations. And this way, the drivers know where they can physically manage to operate, and there is also an infrastructure in place that supports the operation of these vehicles. And community members equally so. They're familiar with these vehicles and with the drivers, and so there was really little barrier to acceptance or entry. And the infrastructure that was already in place included transport companies and associations or cooperatives, and they were very well known and respected. And these cooperatives, for example, they have really high level of participation in their communities and high level of membership, and they're quite respected by drivers, and they have a lot of influence in how the system functions and how it's managed. So with their support, we figured that we'd be able to hold drivers accountable if they were to take part in an emergency transport scheme. And they were a really logical into the sector. Next slide, please. So when we were looking at vehicle availability, public transport vehicles are regularly available and on the road operating during the daytime. And so there is, and at the time was, an understanding that emergency evacuations are also prioritized when they occur and a vehicle is operating nearby. So in the evening, vehicles are not always regularly running, but they were also on call for emergency situations. So the access to vehicles was really good. And the vehicles which were being regularly used for regular transport were obviously being maintained and serviced. And so there were not really many additional vehicle maintenance activities that had to be introduced from the ground up. So we did end up doing a lot of formal interviews and research into this, which I'll touch on in just a bit, but it was also clear that drivers were very eager to improve their skills and knowledge relating to emergency transport of patients, because drivers regularly encountered these emergency situations, and there was a bit of hesitancy around how to best respond, how to protect patients, and even how to protect themselves, as well as other passengers. So based on the emergency transport activities that Transaid and JSI had implemented previously, including a locally managed emergency transport system with the IMTs, there was an infrastructure that was also in place that could be leveraged for this project that the public transport vehicles could be added into. And then finally, the activities that would be linked to public transport integration would really support the safety and security of drivers, especially at night. And at the time, drivers were often being stopped at checkpoints on the way to health facilities or hospitals, and it was really acting as a significant obstacle for reaching care. So there was a real lack of coordination between the transport sector and the health sector. And so this project would also help to assure that drivers were recognized and trained, and that through the provision of things like hats, badges, vests, that this would help support safe passage to health facilities, especially at night. Next slide, please. So there were a lot of motivations to take on this public transport activity. However, there were also a few challenges that we had identified up front that community members were facing when using public transport, and these needed to be addressed. So many emergencies that happen at night, when there's limited or no available public transport, the price of public transport is immensely higher than it would be for a normal trip using public transport. And although we also saw increased prices during the day, the price hike at night was really significant, up to 15 to 20 times higher than a normal fare. And some of the reasons for this included that patients and families were taking up numerous seats, so they were being charged for all of the seats that were being taken up if a patient was laying down across 3 seats, for example. And also at night, a lot of the larger vehicles like the taxi bus would have a lot of empty seats, so they were charging them for the empty seats as well. So they were aiming to receive the same price that they would normally receive with a full bus. And there was no law on price regulation or any other regulations really relating to emergency transport. And so firstly, drivers weren't obliged to even take a patient in the first place, but most importantly, their prices weren't being regulated at all. Next slide, please. And I briefly mentioned earlier, but there was also no cooperation between the transport sector and the health sector, which was really causing a lot of frustration for drivers. So drivers who were arriving with a patient were often turned away. So after making a long journey, 72 kilometers sometimes, they were being turned away because of the family or the patient's lack of ability to pay, or they were being asked to pay themselves on behalf of the patient. And so the driver was being implicated in a situation where his primary and really only role was to safely transport the patient from A to B. And so that it was decreasing their interest in transporting emergency cases, and we really wanted to address that. And there was also no driver training available about relating to emergency situations, such as, how do we respond to this? How do we ensure hygiene practices? How do we manage a patient? And so the drivers were really hesitant about transporting patients to protect their own safety, but also the safety of patients and other passengers. So for this reason, we felt that the integration of the public transport in the emergency response system was very well timed. And also there was a project going on within the Ministry of Public Transport on road safety that was aiming to improve emergency transport conditions in response to road crash and health emergencies. So that timing was also really well placed. Next slide, please. So the key to the success of this activity, as is with most projects, is doing that preparation work. So we had a lot of preparation work to put in place. One of the key activities was to involve all of the necessary stakeholders and have a really strong understanding of the context. So we wanted this activity to be locally led and managed, and so it had to align with the infrastructure that was already in place. And so we started with interviews and focus groups in several locations throughout the Mahefa Miaraka geography. And we aimed to identify the most appropriate location and as well as the most appropriate mode of transport in that specific location. So to really maximize the potential that an area would benefit from this intervention, and which stakeholders would then have to be implicated in the design, implementation and management. So all of those three elements kind of work together. And in terms of the transport that was identified as most adequate, it was the taxi bus and the bajaj, the motorized three-wheeler, mostly because these were best adapted to the terrain, regularly available and accepted by the community, and they also offered the most safety and relative comfort for patients that would be using these vehicles. And we identified 3 locations where we thought that public transport was already regularly used for emergency transport and that would really benefit from this intervention. So then we moved on to identifying the stakeholders. So in these 3 areas, these stakeholders were implicated and involved in the coordination and oversight of the activities. And so if you think of health stakeholders, this would be Ministry of Health, hospital supervisors, health facility staff, health posts. And in the transport sector, we involved the Ministry of Transport, driving associations and cooperatives, and the drivers themselves. And then we also involved local law enforcement officers who were involved in nightly checkpoints and the management of transport corridors. And also, very important, we engaged very regularly with the community to ensure that they also had a voice in the project. Next slide, please. So once we were able to design the intervention, we began designing the training material as well. And I'll jump into a little bit more detail in a minute, but what was most important is that we had material to support a training of trainers approach, material that was accessible for drivers, and also some material that was giving an overview of what the system looked like and how it worked for stakeholders. And we made sure that all the manuals were illustrated to support accessibility for everyone, and it was translated into French and Malagasy. And so it was essential that the drivers who would be trained would be identifiable as well by health staff, community members, law enforcement. And so we worked with the Ministry of Transport to create official identity cards for them, and to also distribute material like hats and gilet, like kind of reflective jackets. And this was really essential, especially for nighttime checkpoints, and making sure that only train drivers were being used under the ETS banner. And then finally, in order to ensure that the scheme worked for drivers, cooperatives, and community members, the agreement of pricing was really essential. So this was a big discussion topic. As I mentioned earlier, overpricing of transport in emergencies was really common practice in the areas that we were researching, and this made emergency transport really unaffordable for most community members and families. So we didn't want to punish transporters for transporting a patient during an emergency by losing money on fuel either. So we came to an agreement that community members and transporters agreed to, which is that emergency transport would, the patients and the families would cover the cost of fuel for the driver, but nothing more. So for short distances, this was really manageable, and long distances was still considered expensive, but still a significant reduction in the price compared to what it was. And also we engaged with the local mutual health insurance schemes. That was also part of Mahefa and Mahefa Miaraka, who were also able to support some of the costs for those who were engaged in the scheme. Next slide, please. So these are the training materials that we developed for the project. You can see they include a training of trainers manual, a driver's manual, which was mostly just the essential information, and then a job aid that gave an overview of the system. And you'll see it's illustrated, and all of the illustrations were made based on photos taken from the training. And if you're interested in seeing these manuals, they're publicly available both on the Transaid Knowledge Center and the JSI website. Next slide, please. So once we were able to start the training of trainers approach, we focused on 3 topics. So medical evacuation, mobilization of the sick, and situation-specific response. The medical evacuation was very much focused on the preparation that was necessary. So what needs to be in place on a day-to-day basis in your vehicle in case you're called for an emergency. If you're called for an emergency while you're on the job, what needs to be in place, how to prepare, and what are the things you need to do once you've been called about an emergency, developing a clear plan of action, and what all of the activities are that need to take place, and which actors are involved in that, and how you can best communicate with them, coordinate with them, and also coordination with families and patients, and the receiving health personnel that are waiting for the patient. Then the mobilization of the sick was a very tactical aspect of the training. So first we covered the precautions that need to be put in place to protect the driver and the passengers and the patient, very much focused on hygiene. And then the remainder of the training focused on how to mobilize a patient if that was necessary. So if the patient couldn't move themselves and the family wasn't able to support, we used materials that would be available in any community, such as a chair, a sheet, or using even 2 people by connecting their arms to make a makeshift chair. So this training covered how to use these approaches, and then as well the safe positions that a patient could take in a vehicle, and how to get them into a vehicle. And then there was a small first aid actions phase as well, just in case this was necessary, because a lot of drivers said that they come across patients who might be heavily bleeding or would have a broken arm. So we just wanted to make sure that they knew what to do in these situations. And then the situation-specific response was really about how to respond to a specific situation a driver might encounter. And that included a practical session where we enacted out an entire emergency transport situation from A to Z. And then, yeah, as part of the project, drivers were asked to note down basic information about how many times they've carried out an ETS service, so that we could monitor that, and these were submitted through the cooperatives, who then passed on the information to JSI. Next slide, please. All in all, the project was a great success, and we immediately saw the uptake of these train drivers getting involved in the ETS system. So the training was phased across the locations, so it even took a few months to complete all the training. And despite this, we recorded a total of 4,196 patients who used these train drivers to complete a referral or get access to healthcare. So we're going to pass over to my colleague Mahefa, and he's going to talk to you about what specifically took place at one of our sites in Diego.
Thank you for letting me speak. And I am Mahefa, Behavior Change Communication and Mobilization Officer of the Diana region during the Mahefa Miaraka project. And I will talk about the public transport partnership and interrogation into emergency health evacuation in Diego. So before we began the implementation of emergency transport using public transport, we had to select the location that would be most suitable. Based on the scoping research, and we decided that Diego and Ivran axis was well suited for a project for several reasons. First, Ivran is a town situated at 74 kilometers from Diego, where the nearest referral hospital is located. The town is located alongside the National Road number 6, a main road for public transport users. It takes approximately 5 hours to reach Ivran from Diego. The journey passes through 5 towns and several folk towns. These locations are reliant on public transport in order to reach the hospital in Diego. Second, it is the largest municipality in the district of Anivranu too. Anivran had an association of mutual health insurance and a functional box cooperative in place that be able to support the project. There were also active transport cooperatives in place that linked Anivranu with Diego capital. Next slide, please. So the steps we took to set up this emergency transport system were as follows. In June 2019, we started with the context analysis. This activity was initiated in Diego and continued along the entire axis toward Anivranu. The analysis allowed us to introduce the approach to the local authorities and to understand the realities of emergency transport within the local communities, drivers, and local health staff at health posts and health facilities. Locally known as CHP and CSP. This step was essential for the development of the concept It allowed us to adapt the approach to the local context and the reality as it was experienced by community members. In step 2, on April 2020, we began the training of trainers in Diego. The training of trainers was used to ensure sustainability of the project. In this way, new drivers could continue to be trained, especially if existing drivers left the area or the profession. It also ensured that there were champions in place to keep the momentum of the project going. This training of trainer was done via the transport cooperatives and was essential to empowerment them and their drivers. The training also involved stakeholders such as the Ministry of Public Health and the Ministry of Transport in order to support the cooperative between these stakeholders so that they could jointly lead the activity with transport cooperative. In third step, in June 2020, we supported the trainers and cooperative in the identification of drivers for training in Anivuran. This step largely consisted of the recruitment of volunteer transporter, like as a taxi bros, tuk-tuk, and taxi, as well as the involvement of local leaders and potential people were trained, including one local authority member, one vehicle owner,
So we're having a bit of connection trouble with Maheri. I'm just going to give him 1 more minute to see if he can jump back on, and otherwise I will take over there. Sorry about that. Maheri, can you hear us? I think he's actually fallen off. I think he was nearly at the end of his presentation. He was just finishing up saying that several dozen patients were already transported since the early training in Diego. And I was really hoping that he'd be able to stay on long enough to be able to give you a bit of feedback himself from the drivers, the cooperatives, and the communities. So maybe later, if he jumps back on for the.
Sorry, I'm in bad. Hello.
Can you hear us, Maheri?
Hello.
Yes, we can hear you.
Yeah. Sorry. This Hello?
Yeah, please go on.
Yeah. In step number 4, the final step for the Diego region took place in August 2020 and involved the delivery of the material and the negotiation of transport costs. The 23 drivers that were trained in June were equipped with safety vests, professional ID cards, and manuals so that they could begin applying their training. The implementation of reduced fares during emergency was drivers and the community to ensure that they understood the importance of these and to address and hesitancies. It is essential that all stakeholders of the transport system are aware and in support of the emergency transport fare for the successful implementation. And finally, the project was able to officially kick off implementation phase, which included monitoring and reporting. Immediately after delivery of the material and price agreement, the drivers started implementing the approach and issued monthly reports based on their activities. The cooperative were responsible for the delivery of the report to JSI. Advocacy with the traffic police was also carried out at the start of this phase so that the vehicle as carrying out emergency transport were given priority and allowed to pass checkpoint without this issue. Then several dozen patients were transferred.
All right, well, we seem to be having a few more connections problems with Maheri. And it is good that he jumped in earlier because I had already jumped a bit ahead. So I think now he really was saying that several dozen patients were being transferred since they started implementing right away in August 2020. So hopefully Maheri will be able to jump on again in just a second. And in the meantime, I'll carry on and finish off the last few slides. So if we can go to the next slide, please. Yeah, so as you can see from both Maheri's testimonials and also the great data that we've gotten, the public transport activities resulted in some really impactful results for communities and drivers. And the project was met with a lot of enthusiasm and partnership from various actors. So it was a real collaboration, which we're very proud of. And we did have a few challenges along the way that we wanted to note, though. So if there's any future projects that are similar to this one, it's quite good to keep these in mind. So first of all, there was a vehicle maintenance culture in place, which I mentioned at the start. But this was quite limited based on the accessibility to spare parts, and it was very responsive instead of proactive in terms of the maintenance. So it would be important to perhaps include a module with cooperatives and drivers, associations, transport companies on regular vehicle maintenance and sticking to a schedule. That way prevention activities would result in a little bit more of a fluid public transport, emergency public transport activities. And then also identifying some local partners that can help support the maintenance, making sure that they're also have the correct tools and spare parts in place. Then the sensitization of the community members was a bit tricky, just because there was a very sensitive balance between overloading the drivers with emergency calls, but also giving the community access to public transport services. And so during the project, we worked with health workers at health posts and health facilities, and the chef Fokontani, who is the community leaders, to access drivers via associations and cooperatives, instead of the drivers being directly called by the community. And this system did function well. However, the community members were not all aware of the system that was in place with for example, the train drivers and the agreement of the price. So I would say focus also a little bit more on community awareness for accountability, and to make sure that the fair pricing scheme is upheld. So local initiatives such as radio spot, flyers, or other campaigns that are accessible in the region that you're working would be really recommended. And then finally, drivers or their telephone numbers were very frequently changed. So sometimes there was community health volunteers, village leaders, or health facilities that were left without accessible numbers. So we recommend that the transport cooperatives and associations and transport companies maintain their own contact list from their drivers and those that have been trained on emergency transport, so that this is regularly coordinated together with the health facilities, just to make sure that there's no delay in reaching a driver. So this also, again, it supports that regular feedback cycle that's really needed between the health and the transport sector. Next slide, please. So if you would like to learn more about this activity or some of the other access to health activities that we've worked on as part of Mahefa Miaraka, we have several tech briefs and reports available on the JSI website and the Transaid Knowledge Center, including one specifically on emergency transport. And if you have immediate questions that you feel weren't answered in this webinar or that you think of later, you can always send us an email, so info@transaid.org, and we'll make sure to get that to the right person. But in the meantime, we have received quite a bit of great questions that have come up since the presentation. So I'm going to delegate these between Dr. Yvette and Maheri. If Maheri is with us, I'm not sure. Can you hear us, Maheri? All right, so we'll probably start with Dr. Yvette and myself with some of these questions, and then we'll begin with Maheri when he's back online. So
it seems that it's really very hard for him because of the weather. Mm-hmm. It's really a cyclone that passed in this region since yesterday. So I think that it's really very challenging for him to just be with us. Sorry for that.
No, it's okay. I mean, we're really glad that he was able to join us for the most of his presentation already. So,
yeah.
All right. So one of the questions that came in for you, actually, Dr. Yvette, was how were the project locations selected? It only looks like coastal regions, none of the interior of the country.
Yeah. So as you showed in the slide, so we are mostly in the coast part of the country, and only one of the region, Sofia, is really inside. And for this project, especially for the emergency transport system, we had to focus on first if the cooperative as a public transport exists, and where the concentration of population is the most and the need is really high. Mainly they are located in the suburban areas, but are really not too close to the hospitals, but have some issue for accessing these hospitals, but they have a road for doing the travel for accessing the hospitals. That's why we just went to some of the place where we could really combine all of these environment in support of this project.
Perfect. Thanks, Dr. Yvette. All right, we also got the question, why did drivers join? What was their motivation for improving their skills in emergency? Which, it's a great question. I think it surprised us as well, but drivers were actually really motivated to take part. They didn't really need a lot of convincing, because these are, the emergency cases they would come across, maybe not on a daily basis, but they would come across really frequently. And they said, you know, we would really like some training as how to manage the situation, and also the difficult situations, you know, being refused by health facilities and at checkpoints. So they were actually really eager to be able to better serve, you know, their customers and to make a difference in the lives of those who needed emergency transport. So they were actually, we didn't meet any hesitancy from drivers in that sense. Dr. Yvette, what work was done with, oh, sorry, I think I've skipped one. Is the data still being gathered since the project has finished? I think you'd be a good one to know.
So it was really difficult to continue to collect the data from the field because of the project ended, and all of the staff is gone. So in this case, the Ministry of Health, who is supposed to collect all of the data from the emergency health evacuation, so they should have the data, and we are not able to access the data after the project is ending. So we do not have this moment and this opportunity to do that.
Yeah, that is a little bit unfortunate. Is Maheri on by chance? Because I would like to know. He's based up in Diego. Oh no, it doesn't look like it.
Yes.
So
yeah. Mm-hmm.
He's based in Diego, so he interacts still with these groups, I'm sure. So maybe when he's back on, we can also ask Maheri if he's heard anything. Mm-hmm. All right. So we also had somebody ask that we mentioned a price hike in the situational analysis, and did this sort of outprice the service for patients or make it inaccessible, or were some still able to use them? So what would happen, actually, what we found out with a lot of interviews is that patients and families still needed to reach hospitals in a lot of cases. So they would ask for support from their community, and a lot of times they would end up having to take on a debt to be able to transport to the hospital, which then they would be paying off his debt for quite a significant amount of time, considering how expensive it was. So I think a lot of times the transport would still happen, but then there would be a lot of financial burden on the families. And even the drivers a lot of times mentioned that, you know, sometimes they didn't get paid, or they only got paid partly. So I think for both sides it was quite a frustrating situation. Dr. Yvette, so there was a question that came in that asks what work was done with the health sector. So maybe you would like to take that question.
Yeah, so from the public sector in the health side, so they are involved as trainers, and also they know all of the list of these drivers trained, and they can contact them. They interact with them when they transport the patients to first to the CSB, so the basic health center. And then if they need additional transportation for evacuating the patient to the hospital. So they are interacting like that. But it's mainly the Ministry of Transport at the decentralized area that is in charge of conducting all of the transportation, monitoring all of these cooperatives, how they deal with these patients, how they make the transportation safer for the patients. So these are really the duty of the Ministry of Transportation at these areas to maintain that. But from the health side, it's mainly for dealing with the patient safety or transportation to the next referral hospitals, and giving the medication or giving some advice for the first aid for the drivers to make everything in an acceptable way for transportation, for transporting the patient to the hospital.
Super. Thanks, Dr. Yvette. A lot of coordination, definitely, that took place in this project.
Yes.
All right, so question about the emergency kits, first aid kits, for example, and if they were given to the drivers. And unfortunately, we did not give any first aid kits to drivers or vehicles. There is a law in Madagascar that states that all public transport vehicles should be equipped with first aid kit. So we did talk to all of the drivers and cooperatives about this, and they said that it's really hard to find affordable first aid kits to equip their vehicles with. But we really, expressed the importance of having these kits, and as well as a few sanitary materials such as disinfectant for their vehicles, and sheets in case the patient was bleeding and needed to be laid down, for example. So we did cover the materials that we recommended they had, but unfortunately we weren't able to equip them with any first aid kits.
Yeah.
I find this question really good, and I'm going to swing it over to Dr. Yvette. So they're asking, is there a good Samaritan law in the country? If not, how are drivers covered if they inadvertently made injuries or made the emergency worse in the process of transporting, given that they are essentially people who are not educated in emergency response and are not covered by the laws or policies that protect healthcare workers?
Yeah, first, as they are in a public sector and they are part and member of a cooperative, so they have some regulations under that. So they have to follow that first, and and part of this, they have to have a health insurance and an accident insurance for the vehicle. So they are covered under that, but we do not have any specific law for covering them as the emergency transport system when we work with them. But as I said, we also provide them with some first aid practical. So, but it's really very limited. So from the communities, for them to transport the patients, they have to pass through the community emergency plan. So based on that, maybe sometimes it's the responsibility of the community health volunteer to accompany the patients to the basic health center. And when they arrive at the basic health center, so it's also the responsibility of a basic health center, if it's needed, to accompany the patients to the next referral hospital. And in case of there are some injuries or accidents in the road, so as I said, they have to declare it as like an injury or an accident happening during the driving, as they are really a public transport.
Perfect. Thanks, Dr. Yvette. All right, so I had a few questions that I was saving for Maheri, but we'll take those as well. So the first question is, what are the evacuation plans that you mentioned, and how does this fit into the emergency transport system? So during Mahefa, we initiated activities related to evacuation plans. It's basically going to every community and understanding to help them develop a plan in case there is an emergency. So identifying which modes of transport are best for them in terms of evacuating, where the nearest health post and health facility are, where the nearest referral hospital is, who to contact in case of an emergency. And so all of this information is accumulated and put onto a plan that's kept at the chef Fokuntani, generally, sometimes at a health facility. And so the community is able to, they're supposed to be posted in a public place, so the community is able to look at them and refer to them if there's an emergency. And there are also a lot of advocacy and awareness done around this plan so that the community is aware that the plan is there for their reference. So it really is to make sure that the community is aware and is able to know what to do when there's an emergency. And the public transport aspect was then integrated into that if they had drivers near them, or if they were on one of the main routes that had trained drivers, so that they knew that this was also part of the ETS system.
And in addition to that, maybe Kim, if I can add, so this plan is publicly displayed. In some places, everyone can see and can have the information and how to transport, and then to also what is the cost for the transportation for them from their location to the basic health center. Thank you.
Yeah, no, I think that's a great addition, which also, you know, it helps them to determine what is a fair price indeed, so that they're not overcharged. So we keep that accountability in there. Then a question, and Yvette, I'm happy to take this, or if you're happy to take this. After so much success with public transport, emergency transport, why was this intervention limited in terms of geographic scope? I know that you talked earlier already about the geographic scope, but why did we not take this project to more locations?
Yeah, we only show the case of Diego today, but we, for the public transportation experience, we piloted them in 3 regions. So one is in Diego, one is in Sofia, and one is in Mena Bay. So we tried really to expand it in other areas. And we know also that, for example, UNFPA for making the evacuation for pregnant women to deliver at the hospitals. So they already also use the Bajaj in the south of the country, using the same approach for transporting the pregnant women to the hospital. So it really takes some places, but we only focus on our experience as a project of Mahefa Miaraka here.
Yeah, and it was also, you know, it was a great evidence generating project, which we hope Madagascar will recognize, you know, the transport cooperatives will recognize, and hopefully internationally some people will recognize it so that it can be taken further, because there's been a lot of good evidence showing that it is really effective. All right, so then yeah, the training of trainer materials, someone asked where can they be reached. So these are on both the JSI and the Transaid websites. And then there was one last question from Maheri that was asking, did different modes of public transport fulfill different roles as part of the emergency transport scheme? They didn't really fill different roles. It was more so which mode of transport which was best adapted for and most used as well in the different areas that we did our project. So for example, in some areas there was a lot of Bajaj available, and they were really accepted, and especially for the shorter distance to health facilities, for example, these were very useful. And then for the longer distance to referral hospital, for example, these were more apted for the taxi bus. So it depended on the situation as well as on which were available in that particular area. So I think that is all the questions we have. And so we're running very ahead of time, but I'm sure that everybody has incredibly busy days. So I'd just like to thank everyone who came to the webinar. A huge thank you to Dr. Yvette and to Maheri, who were able to join us today. And please do direct any additional questions you have via email. And we really look forward to seeing where the outcomes of this project takes us.
Thank you, everyone. Thank you for participating and attending the meeting today.
Yeah, and thanks for the great questions. We're really engaging. All right, thanks everyone.
Thank you.
Bye.